Hello and welcome to Neurology Made Easy. Today we will start discussing these. This is the third part of the epilepsy syndromes and West syndrome. So West syndrome, it peaks in 3 to 7 months, and there are epileptic spasm, EEG pattern of hips arrhythmia, and developmental regression. So three things: epileptic spasms, EEG pattern of hips arrhythmia, and developmental regression. Hips arrhythmia are high voltage disorganized EEG activity with slow waves, multifocal spikes, sharp waves punctuated by periods of attenuation. So, what is hips arrhythmia? These are the high voltage disorganized EEG activity with slow waves, multifocal spikes, sharp waves punctuated by periods of attenuation. The prognosis is variable. 70% are mentally retarded. ACTH, the treatment, some drugs that are we use are ACTH, prednisone, vigabatrin, valproate, topiramide, or zonisamide. But prognosis is not good. Some important things I have written below also, that West syndrome, any disorder that can lead to brain damage can be an underlying cause of West syndrome, including trauma, brain malformation such as hemimegalencephaly or cortical dysplasia, infection, chromosomal abnormalities such as Down syndrome, neurocutaneous disorders such as tuberous sclerosis complex, Sturge-Weber syndrome, incontinentia pigmentae, different metabolic genetic diseases such as pyridoxine deficiency, non-ketotic hyperglycemia, maple syrup urine disorder, phenylketonuria, mitochondrial encephalopathies, and biotinidase deficiency. Otohara syndrome and an abnormality or mutation in the ARX gene or CDKL5 gene located in chromosomes X. So, West syndrome. First, I told you what is West syndrome, what are the features, and what is the prognosis. Now, I told you a little bit that there can be underlying causes: trauma, brain malformations, chromosomal abnormalities such as Down syndrome, neurocutaneous disorders such as tuberous sclerosis, Sturge-Weber, and the other I mentioned. Then there can be metabolic problems such as phenylketonuria. Then Otohara syndrome patient can also later on turn to West syndrome and later on to Lennox-Gastaut. The most common disorder responsible for West syndrome is tuberous sclerosis complex. Tuberous sclerosis complex is an autosomal dominant genetic disorder associated with seizures, eye, heart, kidney tumors, and skin findings. This syndrome we will also discuss later on. So, we were here, West syndrome. So West syndrome, the important things to remember are that peak is 5 to 7 months, epileptic spasms are there, EEG pattern of hips arrhythmia and developmental regression. And what is hips arrhythmia? That I told you, high voltage disorganized EEG activity with slow waves, multifocal spikes, sharp waves, and punctuated by period of attenuation. And prognosis is variable, but 70% are mentally retarded. And what drugs we use, I told you. Next is LGS, Lennox-Gastaut syndrome. Severe seizures in childhood. Patient usually present before 8 years of age. Okay, severe seizures in childhood. Patient usually present before 8 years of age, and most commonly between 3 and 5 years of age. A slow, less than 2.5 Hz spike and wave pattern on the interictal EEG that is generalized and usually has highest amplitude in the frontal region, also called atypical spike and wave pattern. So a slow, less than 2.5 Hz spike and wave pattern on the interictal EEG that is generalized, and it has highest amplitude in frontal region. No drug has been shown to be highly effective, although valproic acid, lamotrigine, topiramide, rufinamide, felbamate, and clobazam may be helpful. In contrast, carbamazepine can precipitate the drop attacks in some of these children. Clobazam and ketogenic diet, vagus nerve stimulation, and surgery are also options. Corpus callosotomy or lesional epilepsy surgery in patients with hypothalamic hematoma can be considered in refractory cases. So, what other details I have is there are multiple seizure types, particularly tonic and atypical absence seizure, but also atonic and myoclonic seizure. Period of non-convulsive status epilepticus occur in most cases at some stage. A slow less than 2.5 Hz spike wave pattern on interatrial EEG that is generalized and usually has highest amplitude in frontal region that already I mentioned. It is called atypical spike and wave pattern. There is also mental retardation, occasionally progressive with or without other neurological abnormalities. Psychotic symptoms are common. Often neurodevelopment is normal before the first seizure. So multiple seizures, slow, so 2.5 Hz spike wave pattern and mental retardation. These are the three things to remember. Then we have Landau-Kleffner syndrome. Uh, developed normally until the patient developed normally until approximately 3 to 6 years of age, when they begin to lose language function. This is important. Language function, auditory, verbal agnosia. The children behave as they are deaf. They ultimately have difficulty with expressive language and have personality disorders and hyperkinetic behavior. They do not develop any striking behavior associated with autism and spectrum disorder, and they do not manifest a decline of overall cognitive function. Bilateral centrotemporal spikes are seen in EEG and spikes and sharp waves with fields that spread widely throughout both the hemispheres. So spike and wave discharges are here. They do not develop the striking behavior associated with autism spectrum disorder and usually do not manifest a decline of overall cognitive function. When the child falls asleep, the epileptic activity becomes virtually continuous, and it is called then electrical status epilepticus during sleep. So when a child sleeps, the epileptiform activity becomes continuous, and it is called electrical status epilepticus during sleep. To be considered electrical status epilepticus during sleep, more than 80% of the non-REM sleep should be occupied by continuous epileptiform activity. Although an exact cutoff is not specified in the International League Against Epilepsy criteria. Treatment is valproic, levetiracetam, benzodiazepines, steroids, and IVIG, and multiple subpial transaction surgery. So something there is below also that I have written in my notes. See below. This is Landau-Kleffner syndrome, and in Landau-Kleffner syndrome, communication deficit and autism include abnormal development of spoken language and impaired ability to initiate or sustain conversations. The autistic child's language is often stereotyped, repetitive, and idiosyncratic, while echolalia and neologism. Confusing the picture is the fact that seizures may occur in autism and EEG abnormalities are also common. Furthermore, at least a third of autistic toddlers demonstrate neurodevelopmental regression involving language, sociability, play, and cognition. LCAS further represent selective loss of language in association with abnormal paroxysmal EEG, eventually characterized by electrographic status epilepticus of slow wave sleep. Etiology is unknown and various are proposed. This can be genetic, autoimmune, or infection. So next we have absence seizure. In absence seizure, the typical absence seizure is less than 15 seconds, consists of brief staring episodes with behavior arrest, and that may occur tens to 100 times a day. there is generalized 3 hertz spike and wave, slow spike and slow waves discharges. Then we have 4 to 10 years, the age limit, and if before 4 years, then GLUT1 deficiency in 12%, then they respond to ketogenic diet. So we should consider this. If there is absence seizure before 4 years, then GLUT1 deficiency is found in 12%, they respond to ketogenic diet. Treatment is ethosuximide. Next is autosomal dominant nocturnal frontal lobe epilepsy. There are hyperkinetic seizures, so it is from genetics. Autosomal dominant nocturnal. Nocturnal is at night and it's frontal lobe epilepsy. Hyperkinetic seizure, thrashing, jerking during non-REM sleep, awakens patients. Some have epigastric, sensory, and psychic auras. Interictal EEG is normal and video EEG may be helpful. Childhood, it may persist in adults, and mutations CNR, NA4, CHR, NB2, and nicotinic acetylcholine receptors. Treatment is carbamazepine or oxcarbamazepine. Then we have Dose syndrome, and in Dose syndrome, the seizure types are myoclonic, astatic, absence, and generalized tonic-clonic. Bilateral irregular 2 to 3 Hz spike and wave complexes with parietal rhythmic theta. 1 to 5 years is normally the age, and patient is normal mostly before that. It is X-linked dominant. Variable prognosis, normal cognition to severe developmental delay. Treatment is valproic, ethosuximide, levetiracetam, and ketogenic diet. So this was Dose syndrome. It is X-linked dominant. This is important. This is X-linked dominant, and 1 to 5 years of age, and different types of seizures, and bilateral irregular 2 to 3 Hz spike and wave complexes with parietal rhythmic theta, and variable response. Then next we have Aicardi syndrome. Aicardi syndrome. In Aicardi syndrome, we have infantile spasms, chorioretinal lacunae, corpus callosum, agenesis, cataract, and retinal detachment. So what we have is infantile spasm, chorioretinal lacunae, corpus callosum, agenesis, cataract, and retinal detachment. There is burst suppression, asynchrony between two sides, and disorganized background, predominantly in girls, and it's lethal in boys. Next we have Beck's. In Beck's, this is usually during sleep, 70%, mostly mouth, face, extremities are involved, focal, motor, sensory, and autonomic, bilateral, centrotemporal spikes on normal background. Normal exam in labs, 2 to 3 years until mid-teens. Carbamazepine, if prolonged or frequent, only 10% have seizures 5 years after onset. So it has a good prognosis. That mostly Becks are during sleep, mostly face, mouth, and extremity involved, focal, motor, sensory, autonomic, and bilateral centrotemporal spikes are seen. And normal exam in lab and labs and normals 2 to 3 years, and carbamazepine if prolonged or frequent, and only 10% have seizure 5 years after onset. Next is a difficult to pronounce, Panayotopoulos syndrome, early onset childhood occipital epilepsy. There is tonic eye deviation and vomiting. So it is related to the occipital region. There is tonic eye deviation and vomiting, visual auras, visual hallucination and illusion, and partial or generalized tonic seizure. High voltage occipital spikes, 1 to 3 Hz bursts, disappear when eye opening, reappear with eye closure. So with eye opening, they disappear and they reappear with eye closure and darkness. 4 to 8 years start, mean age is 4 to 5 years, and mostly in sleep. treatment not required generally, and there is good prognosis. So becs are also during the sleep, and this early onset childhood occipital epilepsy is also during mostly during sleep, mostly in sleep. And this 1 to 3 has disappear with eye opening and reappear with eye closure or darkness, and dystonic eye deviation, vomiting, and visual auras, partial or GTCs. Gestalt type or late onset childhood occipital epilepsy, there is visual uh, uh, symptoms, and there is hemiclonic convulsions, post-ictal migraine. So visual symptoms can be present, and there can be hemiclonic convulsions and post-ictal migraine. And this pattern is same as above. Difference is this is early onset childhood and this is late onset. Panayotopoulos is early onset and Gestalt is late onset. And 4 to 13 years is the age limit, and mean is 8 years, and variable prognosis. So early onset has good prognosis, but this type has variable prognosis. Next is JME, juvenile myoclonic epilepsy. Typically the patient is healthy young teenager with one or more seizure types. Myoclonic jerks most frequently in morning within the first hour of after awakening. Absence seizures, typical pathet mal seizure that often precedes the other seizure and begin towards the end of the first decade. Generalized tonic-clonic seizure, which also have a tendency to occur on awakening. So these are the seizure types, and they are mostly myoclonic, then absence seizure, and generalized tonic-clonic seizure, and they are usually in the morning time. They are precipitated by alcohol, light, and sleep deprivation. Onset is 12 to 18 years of age. They are lifelong. Less than 25% patients are off meds. Most of them require medication lifelong. Polygenic inheritance, autosomal dominant, and GABA receptor mutation are thought to be associated, and valproate has a good response. So this is the end of our epilepsy syndrome lectures. I had 3 lectures, and now I will tell you briefly what I have written in the end. And yes, we have already discussed it. These are only the abbreviations: BFNE, benign familial neonatal epilepsy; early myoclonic epilepsy. When I wrote SZ, that means seizure; early infantile epileptic epilepsy; and Lennox-Gastaut syndrome. So I hope you like this video, and if you have learned something from this, please write a comment, and if you want more of such videos, please also tell me, and we will see us in another video. You will hear us another, you can hear me in another video, and I will make a video of EEG finding also, what a burst suppression look like, what a 3 Hz spike and wave look like, and how is this, but I will mention it in another EEG. I will make a video over EEG findings. So if you like it, then give me a thumbs up, and then subscribe and share with your friends.